Hey everybody, so this is just a brief discussion of some of the later chapters that have some material on exam one. Much of this material you'll see kind of refers back to earlier chapters in your reading, but it may take it with a different spin or applying it to a different patient population, things of that nature. So I hope that this helps you to focus your studying as you get ready to conquer exam one. And so we'll begin. Okay, so chapter 20 is the chapter on sexual dysfunction, gender identity issues, paraphilias. One of the things we know from our reading of the earlier chapters is that one of the main reasons, the main reason why mental health patients don't seek help for mental health concerns is that societal stigma. There's a stigma associated with admitting that you're depressed or seeking help for depression. And when we are taking care of a group who identifies as LGBT or transgender, they have already faced a great deal of societal stigma. And so the way that we approach those patients can determine whether or not they feel even further stigmatized. When we talked about therapeutic communication, it was important for us to avoid this concept of value judgments. You avoid telling the patient, well, that's not what I would do, right? Or any sort of statement that makes them feel as if we're judging them. Keep in mind that patients may identify with a gender that doesn't correspond with their biological sex. So a person may have chromosomes that would, suggest that they're male, but they may identify as female. And we try to figure out the person's desired gender expression and to refer to them in that manner so that we have that respect and trust. Now, chapter 30 talks about death, dying, and grieving. Just good info for things like the HESI, for example, would be the stages of grief that Kubler-Ross talks about. Patients don't always go through them in a linear order. They may sort of jump back and forth or may start in a different phase. But that would be something good to know for your own enrichment. Another good just clinical tip is be aware that there are position statements from organizations like the ANA that are discussed in your book that may help a nurse in the ethical decision-making process around end-of-life decisions. Okay. Another thing that can be confusing as a new nurse that you may want to look at is the types of basically these things called provider orders for life-sustaining treatment. This is like the patient's code status is what we would commonly refer to this. So are they do not resuscitate? Are they full code? There are various forms of that. And it depends somewhat on the state the patient and the nurse are in, but something to look at. Now here's something that is important to your study for exam one. Keep in mind that grief looks different depending on the timing, right? Is this a sudden death that the person is grieving, or is this an expected death? Something like a long battle with cancer. We're not trying to minimize what the person going through cancer is experiencing. What we're trying to say is that sometimes the grieving process gets started a little bit earlier, and so the patient may be a little bit further along in the situation of anticipatory grief. If they could see the death coming, then they begin the grieving process while their loved one is still alive. Okay, chapter 32 talks about serious mental illness. We've referred to that a bit in the team's discussions. Serious mental illness, just something to be aware of for your practice would be the effects of serious mental illness. So the very beginning of chapter 32 has good information about what are some of the effects. Financial difficulties, difficulty holding a job, risk of incarceration, risk of job loss, things like that. Another thing to understand is how we prioritize the care of our patients. And we can look at Maslow's hierarchy. Keep in mind that sometimes patients with SMI have lost that basic ability to provide self-care. They may come in with extremely poor hygiene, extremely poor self-care. Their blood sugar may be 400 because they haven't been following their diabetes regimen. So we're going to start with things like hygiene, self-care, health, safety. Those are huge priorities in their care. And once we have some of those lower on the pyramid needs taken care of, we can begin to address the higher needs, like making the patient feel accepted and working on their mental health. There's also in this chapter some discussion of the different types of therapy. There's a little bit about CBT. Remember, we said it can be difficult if a patient is acutely psychotic and they can't reason with us. It can be difficult to provide CBT, but it can help with certain things, like a person who chronically deals with auditory hallucinations, recognizing reality versus what is not reality. There's also a little bit of discussion about PHP and IOP. So in other words, these alternatives to being hospitalized. PHP is partial hospitalization program. IOP is intensive outpatient program. Now what's going on here is in PHP and IOP, the patient comes to the hospital every day or almost every day. And instead of staying overnight like you would if you were admitted as an inpatient, you stay at the hospital for a few hours. You work with, you perform activities, go to therapy groups, see your doctor, things like that. And then you go home after a few hours. That's what, and PHP and IOP have little differences, but just for now, understand that there is a difference. Whereas patients who have safety concerns, patients that can't take care of themselves at all, patients who are a danger to themselves or others, they need inpatient care because those patients can't safely go home at the end of the day. Again, societal stigma. It's the number one thing that stops people from getting help. And so we don't want to worsen that and make a patient feel stigmatized. And here's something that's interesting, just for your own personal knowledge. Patients with SMI, we tend to think of some of these patients as coming across as maybe scary or threatening. But keep in mind that patients with SMI are significantly more likely to be victims of crimes than they are to be the actual perpetrators of crimes. Okay. Chapter 34 covers groups. A couple of things I want you to pull from this chapter are there's another discussion of the phases of nurse-patient work, nurse-patient interaction. Remember in that previous chapter on therapeutic relationships that we've already read, we talked about the 4 stages and what goes on during the 4 stages. We have a pre-orientation phase where we do a lot of planning to see the patient, orientation, working phase, and termination phase. So in the orientation phase, for example, we're explaining in a group setting, we are getting to know the group members, and we are explaining the rules of the group, helping each group member get accustomed to the norms and expectations that we have for that group. And then the working phase is where we can get to know or get to actually work on specific issues, because now we've built that trust. We built the trust in the orientation phase. Now we can do the work. And then termination is, hey, the group is almost coming to an end, and how are the patients going to function on their own? What resources have we given them? There's also some good just personal info about dealing with various types of challenging patient behavior, like a patient that won't engage in treatment, or a patient that's disruptive and sort of dominates treatment, interfering with the treatment of others. Good info to read there. And then something you may find personally interesting is the types of groups that are out there. Each one has different rules on, do all the groups have the same, all the patients in the group have the same diagnosis? Is it a very mixed group with patients dealing with different things? Is this an inpatient group where all the patients are on a certain unit? Things like that. Family interventions. So families, so much of the stress that our psychiatric patients have in life surrounds their family, but also it can be a great source of support. Usually it's both. Keep in mind that patients who've been dealing with mental health concerns for a long time, they may have difficulty maintaining those relationships. It's easy for a person to burn bridges if their behavior is not always appropriate. And so it's not uncommon for us to ask for an emergency contact from a seriously ill psychiatric patient, and the patient doesn't have one. It can be very sad. Also, just keep in mind, families look a lot different today than they did even a couple of decades ago. And it's not necessarily the nuclear family with a husband and a wife and 2 kids and a dog, and families look all different configurations. And again, we don't want to stigmatize someone who has a family that's different than our conception of what a family should be. Something for your clinicals that you'll, I think, enjoy. Genograms. There's good discussion in chapter 35 on what a genogram is. And sorry about that. So genograms, they kind of look like family trees at first, but you'll notice that there's some extra markings on the diagrams. Genograms help us to not just figure out who was related to who, but also the nature of those relationships. Were they close relationships? Were there people that were not on speaking terms? People that were very close? Was there potential abuse that was going on between 2 family members? You capture all of that. I think about my great-grandfather when I think about this. He had 10 siblings. But unfortunately, even though his whole family stayed in the same community, he did not stay on speaking terms with a lot of his family. In the end, he, for much of his adult life, only spoke to 2 of his siblings. So if you look at my family tree on Ancestry, you don't get that picture at all. It just looks like any other large family. And it's only through a genogram that you would get that rich information of, okay, this person and this person weren't close. Or there was stress here, there was support here. So very valuable. And I would just encourage you, when you're in your clinical, You want to get a lot of information for the genogram, but you want to be careful how you mark it up. If you mark every single relationship, even if it's not that significant, it starts to look a bit messy. 36. So this is about integrative care. So just some definitions. Alternative medicine is basically going to a non-mainstream provider instead of a conventional provider. So you have back pain and you go to a chiropractor instead of to a physician. Complementary medicine means you use both at the same time, right? It may be that the provider, you may be going to a physician who's also trained in some sort of complementary techniques. Or it may be that you're seeing two providers at the same time. The term integrative means the setup is such that your non-mainstream provider and your conventional provider are seen in a coordinated fashion. To stay on the example of chiropractic, there are some spine centers where they have chiropractors, neurosurgeons, neurologists, pain specialists, MDs and DOs and chiropractors that all work together, and they may actually see the same patient, and each one contributes their own contributions to the plan of care. Integrative care can include things like natural products or herbs, or very commonly mind-body approaches, things like guided imagery, yoga. So we might have a patient who sees their psychiatrist for anxiety medication, but also goes to a yoga class to try and help deal with their problem. So as nurses, it's important to know the nursing role in integrative care. We got to be aware of interactions, particularly with herbal or natural products. For example, a patient shouldn't take St. John's wort along with SSRIs. The other thing it's important for a nurse to do is to stay on top of the evidence. So remember, Peplau says that a nurse is, among other things, a nurse is a bunch of things, but you're a resource person for your patient. So they may ask you, hey, I'm interested in this. Do you think it would help? And if you can access the evidence for a particular type of CAM, you will be of great benefit to that patient. And that's it. I hope that helps you to prioritize your studying and look forward to seeing your success on exam 1. Thanks.